Hello friends, this is Dr. Ashok Kumar. Today we'll see topical phaco in soft cataract. Soft cataracts can be very challenging sometimes. So in the beginning, I am fixating the eye with the instrument called Shepherd's fixation ring and doing the side port with angled MVR blade. This is topical approach and this is temporal phaco. After the side ports, I am using intracameral phenocaine, which helps in better anesthesia and sustained pupillar dilatation throughout the surgery. So trypan blue dye is used to stain the anterior capsule. The dye is being washed. Some suggest use of air and before dyeing, but I really didn't see any kind of difference between the both. Filling the chamber with OVD, and while filling the chamber, the OVD should coat the entire corneal endothelium and make it tight. So starting the rhexis with cystitome. I generally use cystitome. Some use utrata. Whichever is comfortable with you, you please carry on with it. The shape of rhexis may change initially in the beginning. So even if you don't get a circular rhexis, see that it is not having any weak spot. After the rhexis, again we need to fill the chamber with OVD. Again make the eyeball tight. Then again using the fixation ring, using a 2.8 keratome, the main entry is done. It is 2 planar. You can see the wound, construction of the wound. After the main entry, slightly shallow the chamber before hydrodissection so that some of the OVD is removed. Then do a gentle hydrodissection. Shallowing of AC by removing a small amount of OVD helps in easy nuclear prolapse. Once hydro is finished, after you could see the wave, again fill with OVD. Then try nuclear rotation. Hydrodissection and nuclear rotation helps remove any attachment between the cortex and nucleus and easy manipulation during phaco of the nucleus. So once you are satisfied with the rotation, coming to the phaco, generally as a beginner, after entry, as this is topical, you can go into continuous irrigation mode in your machine. First remove any epinucleus and cortex in front of the nucleus. Then start trenching. As this video is dedicated to challenging soft cataract, you could see the trench is not as planned in a routine phaco. You could see either the depth is becoming more. These air bubbles can be irritating. See. So after trenching, always try to get a deeper trench. As this is soft cataract, the nucleus is not that much of crisp in order to get a break. That you could see right from the beginning. So if you are confident in this kind of cases, direct chop will be a better option. But as a beginner surgeons, first do the trench. See, trying to break the quadrants, it is giving away. It is cheesy. Currently it is in US1 mode or quad trench mode or scalp mode. Now changing to quadrant mode or US2 mode, which has high vacuum, and you could see one piece or one quadrant is removed. Yeah, again going to the other quadrant. See, by holding it by the vacuum without using any ultrasound, please bring the piece to the center. Always use your phaco energy at the center. If you are confident, you could use vacuum at the periphery in order to hold or grab any particle. There are also other ways, other suggestions for beginners in order to crack. Cracking after trenching, trying to crack with iris depositor and dialer. Here in this surgery I am not using any kind of Nucleus chopper. I am just using only Sinski. All these videos are suggested for beginners only. Yeah, if you are confident with your phaco machine, you can get epinucleus and cortex as well with the phaco probe itself. And while doing so, if you remove the second instrument and only leave the phaco probe inside, the sensors of machines will act in a better way, because there won't be any wound leak. See, even the cortex can be removed. This I don't suggest to anyone, but it is individual preference. Now switching to IA mode, I generally use bimanual irrigation and aspiration. Before IA, I am using once again phenocaine for better anesthesia. Again fill the chamber with OVD. In IA, during cortex aspiration, the left hand instrument is irrigation and the right hand instrument is aspiration. The beauty of bimanual is you can change the hands of the instrument in order to reach difficult quadrants, so that better cortex cleanup is done. You could see small bits are left. Those small bits on the posterior capsule can be irrigated with irrigation alone by flushing it, or you can use, nowadays machines are coming with cap vac mode with very small aspiration, with very small flow rate and very small vacuum, which is exclusive for PC polishing. And now this is irrigation cannula. I am implanting a foldable hydrophilic posterior chamber lens with hydro irrigation, which doesn't use visco. Yeah, this irrigation cannula is continuously on during the manipulation of the lens and insertion of the lens. After that, once we use aspiration cannula and take away any visco that is left, which will add the speed of the surgery, and also the remnants of visco are less, which will prevent post-op IOP spike. As a beginner surgeon, always take your time in cleaning up the visco, which will add to the post-op clear cornea and also no IOP surge, which the patient appreciates a lot. Once the visco cleanup is meticulously done, then we can move to the next step, which is intracameral installation of preservative-free moxifloxacin and closure of the wounds by stromal hydration. Proper entry with proper instruments adds in better sealing and easy sealing, so that you don't need to waste a lot of time doing stromal hydration and a tight AC is maintained, and when you are confident, the case can be concluded. Please kindly subscribe to this channel so that better videos of step-by-step teaching is done. Thank you.